and a treatment center. And it's really a thing that needed badly. In the US, physicians from India have started this because many of them get heart attack on their own. They come at 38, 40. So today we have a video. It's a little long, but we'll listen to it. And that's that's the essential thing. It's a good talk. And so Maruf is going to play. Maruf is going to play the whole thing off. Maybe the last part, maybe you can cut it off. Maybe, right? Anyway, we'll play it and see how it goes. It's a very, very good talk, very informative talk. And one other thing, Vijay Sekara, Stanley Vijay Sekara is in Mexico. He couldn't join because of that. His son, who's an orthopedic surgeon at Yale, is the speaker next week. And so we should welcome him. Our numbers came down, Bonnie. Normally we have about 25, 30 people. For whatever reason, the numbers came down. I don't think they knew you were coming.
Yeah.
but for some reason, a lot of people. But I think we have to make a concerted effort to bring the numbers up again.
Of course.
With that introduction, anyone else want to say anything? Don,
Karnia,
yeah.
That video is high-flown stuff, and most of the things that are said, we do it fundamentally, and in that what he has stated in that video is high-flown stuff. We don't do it in Sri Lanka, and most of the essential features, I don't think there's nothing to add, and certainly it's not appropriate for us. It's more academic to us to listen to it. It is that study is for 20 to 40 age groups. Study they have done. Anyway, we listen to it.
I know it is, but I have followed part of this, the metabolic syndrome and the diabetic part of it as part of my specialty, but it could be, you may be right on that. However, Vix, I think the target population from us is not us. We've survived. That's why we are here. The target population is the next generation, our children and our friends and their friends' children. So I think we got to sort of propagate the information and knowledge. More than it's not for us. I mean,
it tells us the scope.
Managed to survive, huh?
It tells us the scope very soon. The scope.
Yeah, but it is for your children. It's for your children and your grandchildren and for all the others around. They haven't come up with anything very fancy yet. It's still the same old in diet and exercise and so on. And they're looking at various markers, but still it's fundamental. And have a look and see. I don't know how many. Maruf did give the video earlier for people to watch. You have watched. I don't know whether. Yeah. Padmalinga, you want to say something? No.
No, I think it's. I may have some questions at the end, not right now. Thank you.
Sure. Go ahead. So
that's Maruf, a video.
Yeah. Let me tell you. I'm just going to play the video. We can stop it anytime you want if you felt bored or something like that, because he's giving a reasonably good lecture, but it's 1 hour, 12 minutes, and I don't think we'll run through that. But basically, whenever you stop, main thing is for us to discuss this. It is a stimulant for us to discuss. And the information is very valuable, and it's a good thing for all of us to know. Perhaps it may not apply to us.
It applies to our families.
Our families. This is what Karnian's point, and that's very worthwhile thing to consider. All right.
Our children and our grandchildren, and
that's right.
Yep. Karnian only gives us the scope of possible investigation.
Who cannot come,
what's that?
Even Shanti,
gives us the scope of possible investigation. That applies.
So I'm going to share the screen.
Okay. I will talk about it. Yeah. Sorry, Maruf. Yeah.
Can you?
Yes.
Can you see the screen?
Yep.
No, if you guys want to stop it, or if it's something like that, just send a text, a chat. We'll be looking at the chat. Or if you can talk too, we'll be open. Yeah. Go ahead. Yeah.
It was launched just around 2 months ago with a tremendous amount of support from. I'm really honored to be able to speak to you all about this topic today and to tell you about a new initiative at Stanford that was launched just around 2 months ago with a tremendous amount of support from the hospital and from the community. And We're very grateful for this opportunity, and I want to tell you about it today. And I also want to mention I'm incredibly humbled because I learned that the last time this talk was given, it was given by Jerry Reven, who is one of the founding fathers of the metabolic syndrome and insulin resistance field, which is so much a part of this problem that I'll talk about today. So I'll do my best, but I know I can't measure up to Jerry, but it'll be my honor to try. So today I'm going to talk to you about the Stanford South Asian Translational Heart Initiative. This is a program that will start here at Stanford.
Maruf, the video stopped.
Problems.
Maruf is dealing with that.
Silent, no sound.
Sound is not coming.
Briefly, today we're going to speak about some of the statistics about coronary
Maruf,
disease risk in South Asians and how the traditional risk factors that we use
Yeah, you
for
can
the
watch
general
on
population
YouTube,
apply
if you want.
and also don't apply to this population. I'm going to talk to you also about SATI and how its comprehensive cardiac risk assessment we feel may hopefully improve upon our traditional risk factor assessment in this population. And then speak about our clinic and research goals, and finally, what we think you can do to protect yourself and your family from what is becoming an epidemic. So I want to start with a case today of a patient I had who is a 44-year-old male engineer here in the Bay Area who came to me with no prior history of heart disease. He was young, he's very active, and he said that occasionally he got short of breath, but did not feel like it was exertional. He could run, although it wasn't clear exactly how much he was able to run. He was able to exercise fully, in quotations, 3 times a week, about 40 minutes or so, and said that he didn't have any specific limitations or recent worsening of that. And he said it was usually light running and occasionally cricket. And one can argue about how much cardiovascular activity there is when you're playing cricket. It depends on what you're actually doing. But upon further questioning, it was a mix of running and standing. So he was an occasional smoker, a social smoker on the weekends with friends. He would have a couple glasses of whiskey, perhaps, and a couple cigarettes, but no more than that. His blood pressure was borderline, 135. He had some diabetes laboratory tests that he came to me with, a fasting sugar level or fasting glucose level of 104, which is just marginally elevated, and a hemoglobin A1C, which is a measurement of his last 3 months average glucose level. That index was upper limit of normal, 5.5, but certainly not alarming. He also had a cholesterol profile and was actually pretty close to normal in terms of the major cholesterol and lipid indices that we check. So he had actually come to me as almost a third opinion. He had seen 2 prior cardiologists. One had performed a stress test and it was somewhat equivocal. It hadn't shown a real problem and he wasn't sure what to do about that. A second cardiologist had said he needed an angiogram and he had said no. He said, I'm not interested, it's too aggressive an approach. He felt like his symptoms didn't warrant that kind of an approach. And so he didn't want to do an angiogram, but he did come to see me in Sati Clinic, and this was quite recently. And I spoke to him about his risk factors. And I took a tool that we all use in our clinic that is publicly available as well, where you can enter someone's age and some details about their ethnic background and some of their blood pressure and cholesterol values. And you can see I've entered those for him here. He's a 44-year-old male. He has these HDL, which is the good cholesterol value. A total cholesterol is shown here, systolic blood pressure. He was not diabetic. He did smoke. He did not have high blood pressure. And interestingly enough, the only categorization for ethnicity is white, African-American, or other. And if you look, there's a little disclaimer in the bottom right-hand corner that says that this estimate may underestimate the 10-year and lifetime risk of a cardiac event or cardiovascular event in some race or ethnic groups, and South Asians are actually included here in this disclaimer. And his risk was actually fairly low. Over the next 10 years, it said his risk was 4.9%. The lifetime risk is a fairly generic lifetime calculated risk. It doesn't really vary too much based off your 10-year risk, but it was also in that intermediate range. And again, note the disclaimer. And when you went to the summary page of recommendations, it said that he actually was of a white or other race, and he would not benefit from a statin due to his 10-year cardiovascular risk score of being less than 5%. And so that was, probably the type of approach he may have received from any general physician that was taking care of him. If you plugged in his numbers, this is what it would tell you to do. So the last piece of information that really wasn't accounted for in that calculator I showed you was family history. And so I'm going to draw a family tree for you here. And if you've never seen one before, this pedigree is basically showing him. He's our index patient with a square around it, and his wife here. And piece by piece, his older brother, who was 46 years old, had actually just had a heart attack and had a stent placed at the age of 46. So first degree relative who has had an early cardiac event under the age of 55 for men, under the age of 65 for women. So that brother had had a recent heart attack and stent. And when I then expanded upwards to his mother and his father, his mother had actually had 4 stents, and she was now 70 years old. And even more alarming than her brother having stents were that 3 of his maternal uncles had died from heart attacks under the age of 60. So this is a very severe case of early coronary disease and early coronary events in his family. And I can look out at the crowd and wonder how many of you have had a similar story in your own families, where you've had someone in your family have an early cardiac event. And think about his situation, where on paper and on the traditional calculators, he was not thought to be in the high risk category. But looking at this family tree, I think you would all agree that he's tremendously high risk. So what he did agree to do instead of the angiogram was a coronary CT scan. And a coronary CT scan is like a specialized X-ray of sorts, and it does visualize the lumen of the coronary vessels. And what was seen on this vessel coronary angiogram from the CT scan was that all of his vessels were wide open except the left anterior descending coronary artery, which actually had a 99% blockage in the proximal to mid portion and had some bits of calcium, which is the bright area here, but you can see this vessel looking fairly good until this mid portion, which had a severe blockage. And that's represented here as well. So this was of tremendous concern to him. He actually underwent an unremarkable procedure to stent and open up that blood vessel. He's doing well now. He's on aggressive medical management. But the first thing that he said after I showed him those pictures and I talked to him about his family history and why he needed the angiogram was, why did this happen to me? How can I prevent it from happening again? And how can I protect my children from having the same problem? And these are things that are being raised on a daily basis in our clinic and many others, I'm sure, in terms of how to deal with this problem. So going through some of the statistics, I want to share with you some of the work that's been done and reported by our colleagues here in the Bay Area and others around the world that have looked at the incidence of coronary disease in South Asians. In California, in fact, South Asians have 4 times the number of heart vascular events as any other ethnic group.
It's ridiculous.
They have extremely high rates of insulin resistance and diabetes, dyslipidemia, metabolic syndrome, and vascular inflammation.
Unless, of course, our attention.
And they have heart attacks that not only are happening more frequently, but they happen at a much earlier age. More than half of the heart attacks that are occurring in this population are occurring under the age of 50. Not only that, there's some evidence to suggest that after that first heart attack, that there is approximately a 40% higher mortality in some groups after that heart attack compared to other ethnic groups that are age matched for that event. In India, the problem is not as well studied in terms of some of the demographics of the problem, but there's a lot of data suggesting that the problem is as big, if not bigger. In the early 2000s, coronary and cardiovascular events took over as the #1 cause of death from infectious diseases. And about a third of all deaths in urban India are from cardiovascular events. And as we all know, a large percentage of the rural deaths in India are probably undocumented or not sufficiently documented. So it's not really known exactly how prevalent it is overall, but it's certainly concerning. And actually we have one of my colleagues in the audience here who published this study in 2004, showing that the rate of events in South Asians is approximately 4-fold higher than other ethnic groups here in California. So in India, cardiovascular diseases have killed on the order of 17 million people just a few years ago, 3 in every 10 documented deaths, and the prevalence of disease suggests that it's much higher in South Asians than in Europeans or in Chinese or in other ethnic groups. And it was felt that in 2010, India would be the home to approximately 60% of the world's coronary disease burden. It's unclear if that was confirmed with follow-up studies, but the trend has been alarming in that sense. The InterHeart study was performed by a group in Canada and looked at 1,700 South Asian patients who had suffered a heart attack and compared them to non-South Asians who had had a heart attack and South Asians who had had no heart attacks. MI stands for myocardial infarction here. And they looked at the risk factors that might be contributing to these events and felt that it was a combination of the diet, diabetes, and dyslipidemia in the population.
That's a Canadian study, right?
On average, it's felt that South Asians develop coronary disease about 10 years earlier than other ethnic groups. And they tend to have more severe coronary disease at presentation. And this specifically means that when they do present, they tend to have blockages in upstream locations in the coronary vascular tree, meaning that those blockages affect a larger territory of the muscle on average than one that would be located further down the coronary tree. So that high risk, as well as multi-vessel disease at first presentation, raises the degree of risk for that individual patient. And in the California census, the most recent data suggests that the only demographic that wasn't living longer was the South Asian female demographic. So this is a problem that's not just affecting men who are South Asian, but also women at alarmingly high rates. This was the British Medical Journal study that showed that after a heart attack in the UK, the 6-month mortality was 2-fold higher in South Asians, and that the presence of diabetes accounted for a majority of that increased risk, really shedding a light on the presence of diabetes and insulin resistance as a risk factor, which I'll speak to in more detail. So just to summarize, some of the statistics is that heart disease is now the #1 killer in both the US and India for South Asians. And South Asians between the ages of 20 to 55 can be considered intermediate to high risk based off of that alone. And that aggressive early onset of coronary disease is present in this population with a higher mortality after the first heart attack, and that this disease appears to be occurring progressively earlier as we start to see more and more patients coming in their 40s, 30s, and now 20s with significant coronary disease. Now the question is this because of improved disease reporting, or is this something that's been going on for a while? And I think that answer is still unknown, but there's no doubt that that is a trend that has been recognized. There's also the factors of lifestyle and diet, and those in the context of an economic revolution within South Asia, what impact those have upon patients' lifestyles and diets has been the focus of several studies. So what about traditional risk factors in South Asians? Do they apply to this population? So let's start with smoking. This patient of mine was an occasional smoker, and actually tobacco use suggests that there is a slightly smaller percentage of use of tobacco in South Asians compared to non-South Asians. However, for those patients that do undergo angioplasty for heart attacks, they're more likely to be smokers. So clearly tobacco does correlate with the incidence of heart attacks in the South Asian population. Diet and exercise also play a role in higher risk of heart disease in South Asians. South Asians living in the US are found to eat probably too little fruit and too little meat or fish or protein and too high fat, and that the diet contains instead too much refined grains, sugar, and fatty foods. And then insulin resistance. Insulin resistance is a point along the continuum from a normal glycemic control or glucose control to diabetes. And it's thought to be a precursor to diabetes. And shown down below is a chart that kind of demonstrates the progression from normal to abnormal. And the diminished tissue response to circulating insulin is one way to describe insulin resistance. Insulin, as you may know, helps cells take sugar into them. And without sensitivity to insulin, that sugar level will rise in the bloodstream and not get into cells. And then you have some of the damaging effects of the high sugar as well as the high levels of insulin in the body. So that precursor to diabetes or pre-diabetes is something that carries with it risk, but which is not technically within the range of the diabetic categorization. And that normal lab values for diabetes, a hemoglobin A1C, which I mentioned below, of less than 6, and a borderline fasting glucose are often very consistent with insulin resistant profiles, but are not a diagnosis of insulin resistance in and of themselves. One way to diagnose insulin resistance is using something called an oral glucose tolerance test. There are also several other types of tests to diagnose insulin resistance. These are testing protocols that are actually fairly involved, that are of varying accuracy, but are not routinely done for patients in clinics. That progression to diabetes from insulin resistance may take several years on average to occur. However, during that time, a patient takes on an increased risk of developing atherosclerosis and endothelial damage. And insulin-resistant patients may carry a similar rate of cardiovascular events as diabetics, meaning they may be in a high-risk category, even though they're not recognized as being diabetic. So the diagnosis of insulin resistance seems to take on greater importance in this sense, and that doing an oral glucose tolerance test, and in our case, adding an insulin measurement at the same time. And again, this test is requiring an 8-hour fast, kind of like you're getting your cholesterol checked, and combines checking your glucose as well as checking your insulin at various time points. But that type of a measurement is a very good and accurate way to measure not only whether someone is insulin resistant, but whether it's a mild, moderate, or severe form of insulin resistance. But this test is really not routinely done because it requires the fasting and it requires multiple blood checks. It is a little bit more work for the patient, a little bit more work for the physician and provider, and yet it's a very important test, we think, to be done, especially in this population. And I'll speak as to why, because of the incidence of insulin resistance in South Asians. So what is the prevalence overall of insulin resistance? Well, because most patients are never tested, we don't actually know. But in terms of diabetes, about 23% of South Asian men and about 14% of South Asian women are felt to be diabetic. And we know that about 80 million Americans over the age of 20 are pre-diabetic. That doesn't split into South Asian or not, but one can somewhat surmise that this number of 23 and 14% may be much higher than we suspected. The interesting thing is that insulin resistance and prediabetes can not only be diagnosed, but they can be treated, they can be controlled, and preventing a patient from progressing from insulin resistance to a diabetic state is something that can be achieved but you have to make the diagnosis first before you can actually make that intervention. Lifestyle changes, dietary changes, and if necessary, treatment with metformin, glyburide, pioglitazone, these types of medications can help not only reduce the risk of progression to diabetes, but even improve the sensitivity to insulin, which is the primary problem. Okay, so we talked about insulin resistance, we've talked about smoking. What about obesity? So obesity is a problem in the South Asian community, and it's traditionally measured using body mass index with a cutoff value of 25 kilograms per meter squared, taking into account a patient's body surface area. However, it's a very poor predictor of cardiovascular events in Asians in general. And it's been proposed by the World Health Organization that a lower target BMI may apply to South Asians, in this case, 23 kilograms per meter squared. And that doesn't sound like a lot of a difference, but it's actually a substantial difference. When I looked at myself, I was looking at this and saying, wow, I'm actually overweight for a South Asian. And I never thought of myself as such, but now I do. And as I learn more and more from my colleagues as well as from my patients, I realize that there are changes that I need to make in my lifestyle that are similar to what my patients and I am asking them to make. South Asians suffer from something called the thin fat syndrome. You may have heard this phrase before, where a patient's body type may not appear to be overweight or obese, but in fact, they have a different type of fat called visceral fat, fat that's within the abdomen that you don't necessarily see on the surface, but which coats the organs in the abdomen and elsewhere. And the presence and amount of visceral fat correlates pretty strongly with the incidence of cardiovascular events in patients. And this is something that has been shown not just in South Asians, but in other ethnic groups as well. And it's something that is used clinically, but is again, not traditionally checked in patients. And then lastly, waist circumference and waist to hip ratio are more predictive in South Asians than body mass index is. Part of that is because of the cutoffs we're using, because at any given BMI, a South Asian is likely to have more body fat than a non-South Asian, percentage-wise. Something like a waist to hip ratio or a waist circumference can help to categorize a patient's body habitus, as well as their risk of having metabolic syndrome. And metabolic syndrome is a constellation of findings that is actually rampant in the South Asian population. And I'll talk to you about that a little bit more. So this was published by a colleague of mine, Mintu Thurakia, about 4 years ago, looking at patients that they had measured waist circumference as well as various lab values from our colleagues at the South Asian Heart Center. And in this particular publication, they found that waist circumference plus any two of the following factors would better categorize a patient's metabolic syndrome than other classifications for metabolic syndrome. And in this case, a fasting glucose over 100, triglycerides over 150, a borderline blood pressure, or a low HDL or good cholesterol. Any two of these combined with an elevated or increased waist circumference would qualify as metabolic syndrome. And my patient that I showed you, he had an increased waist circumference. He also had an elevated fasting glucose, and his blood pressure actually was right on the border of this chart. So he clearly met criteria from those alone. And when you looked at the incidence of these criteria in men and women, interestingly, having a high waist circumference was quite prevalent in the South Asian population, and even one of the other risk factors also. When you met the criteria for metabolic syndrome, the number of women who qualified dropped quite a bit, whereas the men held steady at 30% or so. And it's felt overall that the metabolic syndrome prevalence is quite high in the men, but much lower in the women. It's not clear why that would be, but it is an observation that was made. Nevertheless, we use these indices to classify patients as having metabolic syndrome or not. Cholesterol in South Asians is also a risk factor that is true and correlating with events, even using traditional lipid measurements. South Asians are more likely to have elevated triglyceride levels and more likely to have a low HDL level or good cholesterol. In addition to that, and I'll talk a little bit more about this later, South Asians are frequently exhibiting low levels of HDL2B. HDL2B is felt to be responsible for much of the beneficial effect of HDL. And that subfraction of the HDL is low in about 84% of South Asians. So despite having a normal total HDL, you could still be at risk by having a low HDL2B. And again, HDL2B is not something that is traditionally checked in your clinic patients, but it is something that we are looking at closely in our patients in the Sati clinic. Metabolic syndrome, as I mentioned, a huge epidemic among South Asians, much higher in men, it appears, than in women that have been studied, but I won't go too much into that. And here's a graph of the HDL showing the graph of a number of patients that were looked at, male and female, and where their total HDL levels were. And you can see how many of them fell under the low level of HDL and how young these patients were, under the age of 40, having low HDL as a major risk factor. So I mentioned before, body mass index, total cholesterol, they might actually be lower than you would expect for South Asians, but despite having those things, the composition of their cholesterol profile appears to be abnormal. They have elevated levels of other risk factor proteins, such as lipoprotein(a), increased inflammatory factors such as CRP, homocysteine, fibrinogen, and plasminogen activating inhibitor. And they have an increased incidence of insulin resistance, increased rates, and I didn't show this data, of psychosocial stress and depression. And these are all studies that have been published and available to us for many years. But despite this knowledge, it's not a routine part of our evaluation for our patients to look at some of these factors and to act upon them. And how do we act upon them? Which would be outside of the norm of our traditional guidelines for non-South Asian patients. And that's something that is an outstanding question that we've tried to tackle through our clinic and our approach. So just to summarize the traditional risk factors, there are high rates of traditional risk factors in South Asians, and they do correlate with cardiovascular events. However, if you look at the actual scoring of traditional risk, it underestimates the coronary disease risk in South Asians. Whether it's the Framingham score, the Q risk score, the Reynolds score, there are many, many others. These are consistently underestimating the risk that we know exists in this ethnic group. And it's believed that this is a combination of genetic, cultural, dietary, social stress, and even migration factors amongst the population. Insulin resistance is a hidden yet potent risk factor in South Asians. And as a result, because of the failure of traditional risk scoring to really capture the risk in this population, non-traditional screening may add value to that risk assessment. So I want to talk to you now about the Sati Clinic and how we're approaching our patients in this regard, as well as some of our research mission, and then speak a little bit about our comprehensive risk assessment and what that involves for patients. So Sati, as it's pronounced, means companion or friend.
Maruf, you want to stop at this point and just have a discussion or something?
I think so.
Heart disease and risk.
Yes, we have.
For heart disease in South Asians.
We could stop it. Do you want me to stop it?
Because this
Why don't you stop and ask the people?
10 years earlier than other ethnic groups, our target population.
Do you all want to continue for a few minutes more? Or you want to know about the Sati Clinic?
I think it's a good place to stop, Maru.
Yeah,
Yes,
okay.
Yeah. I think let's have a discussion, yeah. But the rest of it is about Sati and its services, more than facts about the...
We have gone through about 30 minutes of the video. If you want to follow, you can actually, the video is available online. But I am trying to contact the man to come and give us reviews. And I have some questions to ask I think Karnian will be able to answer most of the questions. I think
Why don't we stop at this point?
Yeah.
The rest of it is about Sati itself, which is pertinent to. I would suggest that
I think
all
we have
those who are
16 people now.
and Sati also has.
The high-tech stuff is coming after this. Muscle culture and
Sure, you want to go into all that?
coronary myocardial fibrosis and all that.
So do you want to go
it's okay,
forward?
it's all right,
Huh?
No, we'll discuss the
Okay,
more
go on,
important
something.
than
These are clinical aspects of it, and the messages, I don't want to repeat it. The rest of it goes to the, and they are doing in various areas. Number one is they are going into studying the genes involved to identify it. Now, you can identify genes very easily. Number two, they are also going into using of apps to help with lifestyle changes. And they're doing a lot of work on that. And they have a program, which is a three-visit, 6 months program of lifestyle change and coaching, which is more pertinent to the people out here. But recently, they have also started having telemedicine. So, but the only thing about the telemedicine, you can't get all your blood tests done. But there is a treatment arm to it too, prevention arm more than treatment arm. They don't take people who have had coronary artery disease into their clinic, but those who are preventing. Yeah, sorry, go ahead, someone.
Just me.
Any comments or anything? What is your feeling? Do you want to continue or?
So far, Karunian, there's nothing new to pick up. It's the usual stuff he has said. He has quantitated it. He has quantitated it. That's all.
And also made awareness of the risk. The problem is, particularly in Sri Lanka, this is normalized. The abnormal becomes normal. For instance, in Sri Lanka, guys are getting heart disease at 50, 52 and diabetes at 30, 35. I was there recently. I was surprised at the incidence of diabetes in the young. And there is they think the neighbor has it, the friend has it, everyone has it. So they've normalized it. So it's really a public health issue that we have to, be aware of. But they've quantified it and just alerted us to the risk. And also the Caucasian risk factors and risk metrics do not apply to us in terms of risk. We have it.
I think we need to have a risk score of our own.
Yeah.
I think you can develop a risk score based on discussion or further. There's a lot of things that he mentioned that are important. I think you need to review, perhaps start reviewing people at around 25 years. There are people who have died at 25 years. And earlier screening for heart disease. And then the lifestyle and smoking and stress. Stress may be one of the things that is in the Asian mentality, is to be caring and concerned, and that brings you into a stress situation. And what about sleep patterns? Incidence of type 2 diabetes, as Karnian has already pointed out. Family history, should we screen for special family history of heart disease and how they, whether the parents had. Then he had given some important clue to some of those additional lipid profile and additional profile of blood tests that you can screen on. This may be added to our South Asians. And as I said, we could develop a new score. So I think coming from this, I think we should be able to take this across and work on it. And somebody can come up with something suggesting a score and suggesting a profile review of how to screen all South Asian youngsters from about 20 years. I don't know. I think it's your opinion.
Sure. Ranjit, in the medical community in Sri Lanka, how much awareness is there in this kind of stuff?
Medical communities, they are quite aware of all these.
In the general public?
Depends on the area, I think. In the towns and all, they are aware, but I'm not sure about the villages.
Has any friends or family members you think have been affected that we all know?
No, not.
Anyway,
Yes, gone off the screen.
Not many people in that age group.
In our batch, I think Jit was one of the earliest of this problem.
Jit was Jit Gunawardena was perhaps one of the people who had it pretty early and young.
At what age? Beginning.
Good morning.
Morning.
Morning. Hey, Stanley, how are you?
Yeah, from Acapulco.
Yeah, he's in Mexico partying. Yeah, you couldn't get up.
Yeah. Thanks. Your son is going to give us a talk next meeting.
Yes, thank you very much for asking him.
20.
Oh, no, it's a pleasure.
You are delighted to give it.
I know. I had a delightful conversation with him. He's a nice young man.
And his son is talking tomorrow, next meeting, orthopedic surgeon.
Stanley, anyway, my question is, we've had our meeting. Do you want to go, going to the cellular stuff and all is following. If you folks are interested, we can go on. But I think Maruf has also shared the video.
It's in your the document I sent. You can click on it and you'll go in. That's
okay.
Banda, you got any comments?
Yeah, I just want to ask a question. I mean, I need some clarification on this from what he has said. Maybe I missed it. But is this higher amongst recent immigrants, or is it there for those who have been living in, say, the United States for a long time?
No, first of all, the heart burden in South Asians as based on data from India is higher. In India, it's the highest cause of death, and they cause about 10% of the higher burden compared to the other Asians too. Right. So it seems to be a genetic, cultural, dietary factor affecting the whole of South Asia. Now, in the case of the immigrants, all immigrants to the US from South Asia are new immigrants. You see, non-white immigration to the US was not allowed prior to 65. 1965 is when they allowed people like us to come into the country. So it's all relatively new. But in this new population, there is certainly a much higher incidence, 4 times the incidence as the others that they've had. And actually the awareness of this came because of the immigrant population, both in the US and also in England. I think the first study was done in one of the cities in England where they compared Bengalis, Bengali migration in a Bengali community with Caucasian community and found the high incidence. So immigration could be a factor, lifestyle changes could be a factor, but independent of that, the South Asian community has a high incidence. So it's good.
You started by saying that we have to be aware of this for the sake of our children, and this second or third generation people have all been born in this country. They didn't come from Sri Lanka. You know what I mean? So are they also going to undergo the same sort of risk that we managed to survive?
I don't know that fact, and I don't think he has given that fact.
I don't think he
said that. So, but I think that will be studied, I'm sure, in the South Asian community. But I don't know the answer to that question, Banda. But I don't.
Partly acquired, partly genetic, probably.
Yeah,
that's a good question, Banda. Good question.
Yeah,
I have my own anecdotal statistics to mention. My own population in Manna, they used to live in this. Mostly, they used to eat fish for 6 days a week, and on Sunday, when the fishermen don't go to the sea, we used to eat meat. And their population, there was hardly any. I have never heard of in that group of when they were living there, and they were all displaced from Manna, and they were sent out, especially my own family and things like that. They came and settled down in Colombo and in the sub areas there, and quite a number of them started going away. Bye-bye. Because I think that shift for them, their dietary pattern, their way, the livelihood pattern, lifestyle were all changed. So it may be a possibility that this movement from the traditional environment to some other place. And the other thing is the diet is very important. I think
from the fish.
A number of us, when you come, I think we have taken up to meat.
Maruf.
Yes.
Now I know the secret of your success. You are from Mana. My father is from Mana, so I know all about it.
All right.
Yes. But
Yeah,
if you
fish all the
kind of fish. If you continue to listen to his talk, he seemed to stress more on statin, you know. It's an
preventive
statins. Not only lowers the heat and anti-inflammatory as well.
Yes. Statin is anti-inflammatory and it lowers the LDL and so on. So statins has been the savior to a lot of people. But Banda, coming to your thing, Banda, I think the specific question as to the incidence in the second generation born in the US, I don't think we have data yet.
Yes.
But I think they'll be collecting data on that. That's an interesting question. The incidence of, I've known people, South Asians with heart problem, and many of them are migrants, new migrants. But the pattern of diseases in migrant population has changed. The Japanese, for instance, their pattern of certain, say, cancers and so on changed after migration.
Japanese are tall there.
They're taller by about 4 or 5 inches, the next generation, but also certain conditions are not there in the population.
Arul, what kind of fish did they eat in Mana? What kind of
fresh fish?
Salmon?
Fish. Fresh
fish.
Fresh fish.
Definitely. Every day, when I was at home in Mana, I used to go and buy big fish and eat plenty of fish.
What is the kind of fish?
Evening and night.
What is the kind of fish?
Sea fish and arukura, all sorts of fish. I don't know.
I think anything that came from the sea.
Hi, Mohanlal. How are you?
Okay, I've been here. Can I make a comment, Arul, please?
Sure, go ahead.
Now, we all know of families where a number of brothers have died of heart problems. It's among the risk factors mentioned, we all know about the genetic influence as well. I mean, is it possible to know to what extent or to what degree genetic factors play in this amongst the risk factors?
Mohanlal, in the evaluation of family in South Asia now, if someone comes, one of the major risk factors is the family history, as he showed in the clinical case that he presented. So it is a risk factor. Now, as to which particular genetic code or set of alleles are responsible for it, they are doing some studies. They have gone into the molecular level at Stanford, but the information has not come out.
They've got 5 genes. He mentioned 5 genes.
Yeah. So they are studying different genes and to see which is the one that particularly has, because if you can see, you take our family, for instance, both my brothers had cardiac disease in the 40s. And I haven't had any symptomatic disease. I'm sure if you go and look at my heart disease, when it's symptomatic, there isn't no obstruction to the flow, but the vessels itself could be diseased. Now, are there any difference in the genetic profile that has spared me? Is an interesting question. For that, you have to go into the DNAs. They are doing that, but I don't know more than to say that it is a risk factor like smoking or like diabetes. What specific part of it, I don't know the answer to that. And I don't think they know either, but we can look into it. Yeah.
It's a bit personal. You said you lost a nephew. Is it from Parasan or Vijayan?
Vijayan's son. Oh. He was 39 when he got the heart attack.
He's old now, so.
Yeah.
Arun, Padmalingam.
Padmalingam, right?
Yes.
I have a question about, you are an endocrinologist, and the guy was talking about insulin resistance, and obviously he also mentioned the measure of insulin resistance is mostly by the glucose tolerance test. Can you highlight us about, you also mentioned about measuring level of insulin. Can you highlight us as to what you do as an endocrinologist in these diabetics?
Sure. So the first of all, insulin resistance is a measure of how effective a particular dose of insulin is in disposing glucose out of the blood. Okay. In the research setting, it is a complicated study. It is done by infusing glucose and infusing insulin and trying to keep it at a level. It's a very complicated study to measure that. For clinical practice purposes, there is no real number or measurement of insulin resistance available now. So we just make a general statement. For instance, it's not like saying blood glucose is 80 or blood glucose is 120. There is no number like blood pressure or something to say. It's a functional concept, the resistance itself. They haven't developed anything to give you one number to say this is your insulin resistance. In research settings, they have complicated protocols by which you can do it. However, there are some things that are surrogates, or they give you an indication of presence of insulin resistance. Those are the 5 metabolic syndrome things. That is your belly size. If you have a large belly and a large hip to weight ratio, then you have most likely insulin resistance. Number 2 is if you have a low HDL, you are most likely to have a insulin resistance. Insulin resistance is also associated with hypertension. So what we have is indirect clinical indicators of insulin resistance than a measurement per se. However, in this particular clinic, they are using another measure, and they are trying to categorize it in their own way, which is to do a glucose tolerance, put a lot of glucose and see how much of insulin comes out in response to it. So depending on if you give glucose tolerance and then have normal glucose, but you need lots of insulin, your insulin level is high, that means your insulin level resistance is high. Okay, in insulin resistance, your insulin levels are higher for the same glucose level to a non-insulin resistant patient. So there are very indirect measurement, and this particular thing they are using at Stanford, they are only using at Stanford. I know some people are trying to measure a number to diagnose and treat, but it is not developed yet. I don't know whether I clarified your answer.
Yeah, I think I got a better idea about it, but one more question is about vitamin E and the use of beta carotene. Do you have any advice about the use of vitamin E or beta carotene?
I don't have any special knowledge on that, but I think vitamin E is a little overrated and is not given anymore. But I don't know. Anyone else knows about vitamin E?
Vitamin E is mainly immune booster, and that's known. And in the COVID era, we are taking vitamin E as a special.
Vitamin D is definitely an immune booster. I don't know about vitamin E. Yeah.
Vitamin E is an antioxidant. That's all the main thing.
Good to see Lawrence here. Hi, Lawrence. Bonnie, you see Lawrence Ratnasabhavati?
Lawrence, how are you?
Can't see him.
He's having his breakfast.
Hi, Lawrence.
You're muted, Majan.
No, he's not muted.
We were good friends at one time.
Huh?
Okay.
We were good friends at one time, Lawrence.
Yeah.
Okay. All right. Any other comments or questions?
just a couple of interesting comments that I can make, Karunian, on this. But before I do that, I must tell you, we got very bad weather in New Zealand at the moment, not so much in Wellington. So there could be an interruption to this connection. But there are two populations that are very interesting. One is a population from Japan, which you've already mentioned. The Americans, cardiologists and researchers have studied that population quite a lot. So you'll find a lot of literature about American migrants. Some stayed in Hawaii, the others came all the way to the States, mainly California, etc. And if you compare them, those who remained behind in Japan, there's a vast difference in various cancers as well as heart disease. They come. The other population, which is interesting and very close to us, is the Pacific Island population. A lot of them have come to New Zealand, and before they arrive here, they have been subsisting mainly on a fish and coconut diet, which is pretty similar to what I'd heard earlier about some parts of Sri Lanka. And when they come...
Panda, we lost you. Panda?
Sound. You mentioned it already.
The weather, he was warning us about the weather.
Yeah.
I think we'll wait for Banda to come back.
I got another, I'm doing some work on this.
So it's more like the food that we eat as a definition.
I mean, it's a whole bunch of, as he pointed out, there's a bunch of cultural factors: food, stress, genetic, smoking, diabetes, all those factors, yeah.
Can I add one more, which is nature and negative ions? I think there is a lot of information, and I'm going to put it in the our group WhatsApp. This and also I'll send it by email. There is a lot of information on this, and these negative ions are absolutely. And I'm wearing one of those devices which actually produce negative ion. It is also anti-aging.
Okay. We believe you, Mari. Whatever you do, you have certainly fought aging very well, Maru.
No, but I'm getting into this.
Are we going to proceed with this talk or what? Are we going to continue with it or not?
Okay. What is the consensus? Do you want to continue with the rest of it? You go into interesting aspects. Who is against it?
In my opinion, I think we got a stimulus. Now our discussion is more important than that one because that is available all the time. You can always go and watch it.
Okay.
So tell us, Maruf, tell us more about these negative ions.
Oh my God, I have a presentation, but that I will do it next time if you want.
Okay, wonderful. That'll be good.
And I
No,
will
not next time. Next time is Vijay's son.
Yeah, the time after that, yeah.
Next time, sometime in the future. But I want to talk about one more thing. If you are we going to have the reunion?
Sorry.
It all depends what you put in your body.
Yeah, that's one of the variables, but
maybe
not the only thing.
Maybe injection, maybe oral, what you ingest.
Yes, certainly what you ingest is important. But...
Stanley, what are you specialized in? Stanley,
Me, pediatrics.
What is your specialty?
Yeah. Pediatrics.
Oh, pediatrician. Oh.
Babies.
Yeah.
Pediatrics.
Can you hear me?
That communication.
Yeah, sure. Benita, go ahead. Benita?
Can you hear me?
Yes.
Okay.
Yeah, we can hear.
Just explain to me that what we're discussing about the insulin resistance diabetes. So, all right, if the patient is diagnosed with the insulin resistant diabetes, especially in the young age, as in this age, how do you set about managing it to prevent the heart attack?
Well, the first of all,
your diagnosis is made with a high insulin and high glucose.
Yeah.
And you adjust your anyway. I will I will think that doses are adjusted or whatever that is, and you bring them under control. How do you prevent or the plaque or whatever coming in the heart?
Yeah, the question is, you're asking is, supposing you decrease the insulin resistance, and the ways of doing that is essentially by weight loss, because insulin resistance is associated with the fat and the weight. Okay, so if you get thinner, your insulin resistance improves. You become more sensitive to insulin. So weight loss. The second is, there are medications, specifically metformin decreases insulin resistance. Okay, and then there is the glitazones, you know, the one category of the anti-diabetic medication that work by decreasing insulin resistance, and therefore you treat your diabetes by increasing insulin resistance. So both those do it. Now the question you are asking is, if you do both those, would your incidence of cardiac disease come down? Okay,
yeah, that's right.
And I don't know the answer to that, and I don't think we have exactly found out measuring insulin resistance, because I don't know of any clinic that routinely has some index of assessing insulin resistance as part of the heart disease workup. The Caucasians don't do it. The regular mainstream cardiac people don't look at insulin resistance as a risk factor. But this clinic has started doing it. So hopefully at some point they'll be able to tell us, because they are doing it and following it up. So you got to do insulin resistance at the onset, then you give some lifestyle changes and maybe medications, and then test for insulin resistance again using the same method 1 or 2 years afterwards, and then see what the cardiac incidence. So the information to that, whether insulin resistance improvement itself will decrease heart disease, we don't know. There's no data. However, intuitively you would think it would.
Yeah.
Intuitively you would. Yeah.
So the statistics show that there is a high incidence, correct?
So there's an association with insulin. It is statistics, but part of the treatment is to treat insulin resistance. I mean, high insulin resistance is bad for a variety of reasons. Okay, so you got to get your weight down. The main way of treating insulin resistance is to get your fat down. And the secondary are medications. You know, there's medications, specific medications that will decrease your insulin resistance. Increase your increase sensitivity, decrease resistance.
Coming to the medication, Karunan, you mentioned metformin.
Yes.
What is the other group you mentioned?
Thioglytazones.
Examples?
They got into. I haven't used those. It was anti-diabetic, very, very popular anti-diabetic medicines, which specifically worked on insulin resistance. Unfortunately, there has been I haven't used the medicine because it's not popularly used. It is still approved, but we don't use it because it increases in the heart failure. It retains fluids and increases the morbidity of congestive heart failure. And so it got out of popularity. I'm not getting the name. I don't prescribe it.
The name is diabetes, I think.
Not diabetes. I'll tell you in a minute. Yeah.
Thioglutazine, right?
The thioglytazones. There are two medications.
Yeah.
There were two very popular medicines, and I'll tell you. And they are both out of fashion nowadays.
I think I take one.
But yeah, pioglitazone. The popular name was pioglitazone and rosiglitazone. Rosiglitazone and pioglitazone, and the commercial names were.
Actose.
Actose is one. Actose and some. I haven't used it for a long time. Rosiglitazone and pioglitazone. Actose was one.
Thank you.
Even now they use it, but it's not. There are a lot of lawsuits and so on and so forth, and it got out of favor. And exercise, it's a very interesting exercise. If you look at insulin-resistant concentration on a monocyte, and you exercise, when you exercise, the concentration of insulin receptors increases in the monocyte. So exercise is one way to decrease your insulin resistance. There are a lot of interesting physiological factors.
So what about the other HDL, or whatever that's, how does that come?
No, there are two things, Benita. Number one, most of us, if you look at most of us, South Asians, and you do a cholesterol level, the high density cholesterol, HDL, which is the protective cholesterol, is decreased. The number is decreased. 40 is said to be the normal.
I know you got out on the...
Most of it, I don't know what, if you know your cholesterol, you'll find your HDL is low. My HDL is low.
The internet is out, huh?
So the protective cholesterol is low.
I will tell.
And they express it as a HDL-LDL ratio.
Don't worry.
And that shows that your ratio is low. Even if your LDL is low, LDL is the good cholesterol, but the protective cholesterol, the LDL is the bad cholesterol. The good cholesterol value is low. So HDL is low. Now in the HDL, there is a subtraction of HDL. For instance, if you take alcohol, your HDL level will go up.
You're very excited then.
But the subfraction that goes up is not protective. The HDL itself has a number of subfractions, and HDL-L2 is a particular subfraction of HDL that protects against heart disease. And so in South Asians, the HDL-L2 is low.
So how do you improve or increase the L2 level?
There is no way of increasing the HDL level except exercise. Exercise, diet, weight loss, these marginally increase it, but there is nothing. It's not like LDL. In the case of LDL, which is the bad cholesterol, you give statins, it comes down. There's no question about it. The problem with coming down is, see, you can have a normal LDL, but again, there are smaller fractions of LDL called LPL, LPLA, which is very atherogenic. And that may not come down. So even if you have normal LDL, you may be still prone to it because the distribution of the subtraction of LPA, if you have small dense LPA, you have a higher risk of coronary heart disease. So there's a lot of finesses in these things. And
HDL is raised by drugs or diet or exercise. Does it make a difference to the prognosis?
If the HDL?
Yes.
Yeah,
so can you manipulate the HDL and reduce your chance of dying?
See, Bobby, manipulation of HDL by medications is not available, okay? For a while, they thought niacin was doing it, but they've given it up now for a variety of reasons. So there is no medicines to increase your HDL. Okay.
Diet and the exercise.
Yeah, diet and exercise tends to increase it, but whether it has an impact on cardiac outcomes, I don't know. I haven't seen any. Yeah, I don't know. I mean, there might be studies, but I don't know.
It's probably unmodifiable risk factor.
Yes, like your genetics, like the family history. There are modifiable.
So with the family history,
there's a limit to which HDL too much HDL is also bad, isn't it?
1 second, hold on, one person at a time. Benita, go ahead. Ladies first.
Too much HDL over 60 is also bad.
No. I don't know about it being bad, but certainly if it is over 60, it's protective. They say a high HDL is cardiac.
I heard there are new studies saying that too much is also.
Okay, maybe I haven't seen
so
that.
Bad.
Yeah, okay. But generally people who have over 60 HDL don't get heart disease is what I've been told. They are protected. And there are a few people I've seen with very high HDL, you know. But there are new studies I may not know. Yeah.
And you are saying carbonate alcohol increases the HDL.
Alcohol increases the HDL, but not the subfraction that is protective of the heart.
Oh, yeah.
But don't tell this to your wife. You can still drink the alcohol.
He is now a teetotaler.
Okay.
Yeah.
Maru doesn't drink.
Hey, listen. I'm going to share a few slides, which will be making you think. And if you don't mind, okay, here you are. And I'm going to just run that particular thing through. Okay, the future vision. Okay, and then here you are. it's a thing. Negative ions are good for us, and it alleviates. You know, you get it in the seaside. So go for your holidays. Unfortunately, COVID is going to prevent us from going for the holidays. Okay, and definitely the positive ions are coming from our air conditioners, car fumes, combustions, and various things that we are naturally used to, and of course from the food that we eat, of course. And this is some of the interesting things about the negative ion. It prevents and gives you better sleep, definitely against virus and bacteria, wound healing, skin health, liver, and it's a sort of a very wide range of activity. And this is you produce, you know, in the sea beach you get about 5,000 ions per square centimeter, and this one produces about a millions. So that's very valuable. So it's a futuristic life care device. You see that? Elimination of lactic acid, anti-aging effect, increased immunity, increased natural healing power. And there is, of course, a book on this, how it helps mental health. This has been proven, because definitely for depression, for example, drugs is not going to help. Definitely no. This one, yes. If you get positive ion around them. And that you get it where we have in Sri Lanka. Of course, if you can go to Sri Lanka to the waterfalls and things like that, it'll be fantastic. And even for negative ladies. And this is the sort of range of, see, the lowest is in the factory workers and in those city areas. So these are unhealthy areas. And so that we are involved in that. The high mountain areas, forest and waterfall, how often do we go? And this is the iron that I'm talking about, CS iron. And this is in the North Pole and the South Pole. There is a more negative ions in the North Pole. That's it. Short one.
Oh, thank you. Thank you.
Okay. Now we can continue.
So basically, nature gives you negative ions.
Yes.
Nature. Okay, good.
So can I ask you, Maruf?
Yeah.
Sorry. Stanley, are you talking?
Yes, I am.
Stanley.
Hey, Kota.
No, I was going to ask Maruf.
Okay.
This, negative and positive ions. What about keeping your iPhone by you at night and having it charging by your bed? Is that a thing that
definitely that is going to give you positive ions?
Is that good thing or bad?
Bad thing, definitely.
I think it's a bad thing. That is, a lot of people tend to keep your telephone by you and charging by you as well.
That's not at all.
Keep the wife.
That has been proven. So I think, Mohanlal, I can give you one device if you like, and come and have and try it and let me know. Anybody in London?
No, but you're talking of medicine at the molecular and cellular levels, and we should do that at one point. You should give us a talk, Mark.
This is a way we are going, and I think we need to talk about that.
But I disagree with you that medications don't do any help in depression. Lawrence is here, and I have personally seen medications does help depression. You're putting Lawrence out of business. Lawrence, what do you think?
No. I'm talking about depression. When you compare with negative ions and drugs, the drugs are there are about 40 drugs, but they don't work. They don't work that effectively as
I don't think so. What do you think, Lawrence?
Lawrence, are you there?
You're muted.
There is Lawrence. I haven't seen him. Haven't heard him.
He's watching on his screen.
He's there. Lawrence? He's next to
Lawrence, we
VGS.
can't hear you.
Stanley. Lawrence.
Lawrence.
There is Lawrence.
Yeah, now we can hear you.
Lawrence.
Okay. No,
He's
we
waving.
can't hear you.
This is Bonilina, Lawrence. Long time no see. Anyway, coming back to medication, I would strongly agree with Karunian. There are some medications for depression which are life-saving.
Lawrence there with us on the screen, but no sound from him.
Yeah, some medications for depression are life-saving.
I have sent the boss. Yeah, I agree. I think, in my opinion, quite a large number of medications, the side effects. I think I don't take medication unnecessarily, and some of the things that we are boosting, and we are boosting the you know this that the whole medication and it is not going to help that as well as the natural healing. There is one side of it we don't look at: homeopathy, Ayurvedic medicine, natural medicines. All this we are brainwashed to give medication and treat illness. No, I don't agree with that at all. Lawrence.
Well, I agree with you, Maruf. Medication by itself is not enough.
No, definitely
but you
not.
got to combine it. You have to take a holistic approach.
That's right.
Mindfulness, mindful techniques, diet. All those things are very, very important. Yes, a combined holistic approach.
Unfortunately, in UK, we have an approach. Dumping the medication is the most important thing. and in quite a number of countries, it's that, unfortunately. But the holistic approach has to come back. And that's why the molecular things and the devices like this are coming out. And we have a few devices at the moment.
Okay. All right.
I want to make a statement, Karunian.
Sure, go ahead.
Lawrence, welcome.
Pathalingam. The human body is a marvelous unit created so meticulously by the good Lord Almighty that it tends to heal by itself most of the time. Doctors, hospitals, and all these people are there to make money.
This is paddy philosophy. That is quite a good thing. Interesting.
Karunian,
Okay,
I have to leave actually.
Okay. Yaso, thank you, Yaso. Yaso,
Okay,
come in next month.
I'll see you next time.
Try and get all the British folks to come. We are going to have a wonderful talk by a wonderful young man. So do come.
Hi, Yaso. Bye. Nice
He'll tell you how to keep you back. Take
Bye.
care, Yaso. Thanks for joining, Yaso.
Bye.
Bye.
Bye, Yaso.
Can I ask a question?
So, Lawrence.
Yes.
Yeah, there has been a sustained attack on your practice of medicine that psychiatrists push drugs that are of no value and that iron supersedes the medications. I disagree with that. I think antidepressants and psychiatric medicines are used properly are absolute miracles.
Absolutely. Well, there's 40 years of double-blind research.
And Lena started the treatment of drug addiction.
Antidepressants.
So, Lawrence, what is your view?
Antidepressants in double-blind trials come out very well for severe depression. We are talking about clinical depression. For mild to moderate depression, the evidence is not good. So for severe depression, unquestionable, all the meta-analysis come out that it's significant. If you're talking about mild to moderate, yes, it's a waste of time. But if you're talking about severe clinical depression, most certainly.
So SSRIs don't work?
SSRIs work very well, and probably the safest of the whole lot. I mean, there are lots of side effects with all these drugs, but in severe depression, the advantages outweigh the disadvantages. So, I mean, basically there's something called the Hamilton score, and if you're scoring above 21, severe sleep disturbance, appetite disturbance, mood disturbance, severe somatic pain, lack of drive, lack of interest, suicidality. For 30 years. I did not know you. If you score 22 on that, yes, sir. They don't work in 100, but they work in about of people. And if you combine it with things like mindfulness, meditation, psychotherapy to deal with the life and social issues, you get an even better result. Yeah.
Yes, Stanley, you put up your hand up. Stanley?
You.
Munada, you want to ask something? Your hand is up in the corner of your picture.
No, I'm okay. I'm listening.
Okay.
I have a question before you close up.
Yeah.
This visceral fat. How do you treat visceral fat? How do you reduce visceral fat?
There is no specific, it's genetically inclined, and this is fat that accumulates in the abdominal belly as against the fat in the, and also around the intestine, the kidneys and all that.
Yeah.
And the only way to decrease it that I know is to decrease the total fat content of the body, which is to decrease caloric intake.
What about keto diet for belly fat?
Beg your pardon?
Truncal obesity, what about keto diet?
I have not been you can eat any hypocaloric diet and you lose weight. I don't think the keto diet, I haven't studied it, but I'm not a great fan of it. I think balanced, low caloric content diet is the safest.
Low carbohydrate diet has been emphasized, but then in the meantime, keto diet has a small place in truncal obesity.
Well, I haven't done it. I haven't looked at any studies, but I think getting the body into ketotic state is not a good idea.
Yeah.
Okay. I think there is a normal energy production mechanism, which is to have aerobic thing, and ketosis comes when the aerobic system fails or you don't give enough fuel for it, and so you use alternate fuel, and you certainly will lose weight because you're hypocaloric. So I'm not a fan on it. I haven't studied any. Don't know any studies. A lot of hype on all this.
How many of the healthy animals eat rice and bread?
Some degree of carbohydrates are needed.
I think fruits are the carbohydrates, but rice, pittu, idiyappam, we take the flour and make it into a more palatable, more enjoyable thing, and we are living on taste. Yeah.
It's a quantity. It's quantification.
Quantity more than the and the addition, because I think people.
No, but someone has to.
One of the things is each time you eat multiple times, each time you stimulate insulin production, and that will cause storage of your carbohydrate into fat.
Yeah, no, but Maruf, insulin, see, of all the materials we take into our bodies, calcium, water and all that, for everything we got a balancing system by which we excrete it out. Say, supposing you take too much iron, there's absorption is blocked. If you take too much calcium, there's a very elegant mechanism to make sure calcium level is normal. The only thing that's an exception is calories, energy. When you take more energy than you need, it is stored. It is not excreted. Okay. And the storing mechanism includes insulin, which is the one that makes it possible to convert the glucose into fat to store it. However, if you don't take excess fat or excess carbohydrate, there is no fat to be stored if you utilize all the calories you eat. So the point I'm making is bottom line, what you need is control of food intake, rather than the quality of food intake. But anyway, I will stop at that. Bonnie and Padmalingam had questions or comments. One of the days we should discuss. Yeah, Bonnie, go ahead.
Yeah, Bonnie. My wife.
Regular
Sujata.
exercise.
Abdominal.
Abdominal exercise is very, very important.
For the abdominal fat.
Yes.
There are some specific exercises which will bring down your abdominal fat. So that's something to keep in mind. Exercises involving abdominal fat. Okay? Abdominal muscles, rather.
I think there is a lot of activity software available for mobile phones, and this is one of the benefits we can have. And I have this speedometer thing. I walk for about 1 hour, and then I get about 10,000 steps, and that keeps me going on the balance of not increasing my kilograms by one.
There's an app called the MyFitnessPal, and if you use it for 2 weeks and quantify the food you eat, including weighing, you will have so much awareness of what you eat. You can lose your weight and control your caloric intake. MyFitnessPal, I strongly recommend it, and that will give you the caloric content of a idiyappam, of a pittu, of rice. Only thing, you got to measure everything. And I know, for instance, it has a barcode, and all the foods in the West at least is barcoded, and it'll tell you exactly what it is. Even marketing department Kitul Pani is barcoded. So I want to eat a little bit of it, and I put my app, and it told me exactly how many calories and how many tablespoons it has. So with that, you can get awareness and really improve your diet. I would recommend that to anyone who wants to manage the diet strongly.
Are you not going to use a Fitbit 4?
What is a Fit?
Fitbit 4.
Oh, Fitbit 4, yeah. Fitbit also gives you the counting. iPhones
was mentioned last time by Nalaga.
Nalaga, yeah.
Monitors your sleep.
Sleep.
Even this one monitors your sleep, the Apple phone.
Yeah. iPhone does it. iWatch does it.
iWatch does it, yeah.
Yeah. My iPhone also has a sleep. It tells me how badly I have slept.
Rule, can I make another comment which is not directly connected with what I've been talking about? But situation in Sri Lanka with regard to COVID, and I think it's in a terrible state. When you have a health minister who thinks that COVID can be destroyed by drinking some pani or something and throwing some sort of a clay into a river, and she nearly died apparently from all accounts. The situation has gone from bad to worse, I think, and a lot of people, it is locked down for a week at a time or something. It's terrible. People can't go and get their provisions or anything. I don't know. Our college has been trying to help hospitals to get necessary things which are not available, some simple, useful things. So I think the situation in Sri Lanka has become totally uncontrollable.
Sure. What can we do is the question
we can't
you're asking.
do much, but the thing is, it's a stable situation that it has got into.
Sure. Ranjit, do you have any in the US? There's a lot of organizations that are working to help very specifically, and also the USAID is going to send a plane full of stuff. The requests have been mainly for oxygen concentrators and respirators and CPAP machines and so on, which I think is really not that's the acute care capacity of Sri Lanka is not high. It is mainly in district hospitals. Okay, so except for the oxygen concentrator, which can take oxygen and convert it, I think many of the other things, you can't just send a respirator and have people manage it. You need trained folks. So I think the real strategy is what they are doing now is really isolation and prevent the spreads, and also vaccines, which unfortunately doesn't seem to be a possibility. The lot of requests have come for equipment, and people are responding in many places. I know the issue is that no amount of 5 respirators and 10 CPAP machines will save some people, sure, but it won't be able to meet the capacity needed if there is a real outbreak. So I think prevention, vaccination is the way to go.
Vaccination is a very important thing.
Yeah, but Ranjit, you can give us update. Except for the doctors and Western province, no one else has got vaccinated.
There are a lot of people, I think 600,000 who have got the first dose of AstraZeneca, and they're still waiting for the second dose.
I know. Actually, in the US, we had a meeting with the State Department and all that, and some of the Sri Lanka Medical Association of US, this guy Trikanti was there. They're all asking for the second dose of AstraZeneca, 600,000. US has not allowed to, is not going to release it. They got a lot of it in store. They're not giving it because FDA has not approved it. So that's a bit of I don't know exactly what's going to happen. But even if they have one dose, we have substantially immunized. I think it's better to get the whole population the first dose of anything rather than wait for the second dose. But I know they all talked about it.
I have a point to make. I think some private organization offered 25 million worth of AstraZeneca. It was refused in preference of Chinese vaccine, and they brought Chinese vaccine. Therefore, some people think Sri Lanka will be changed to Chi Lanka, CHI Lanka, because I think it's an awful thing that's happening, and we are actually, the long-term problem that's going to exist for Sri Lanka is very unbearable.
Yeah, but coming to the COVID itself, there's nothing wrong with the Chinese vaccine. I mean, why do you think if you get vaccines, give it?
Yeah, that's
Chinese. They have
but I'm talking about these people who have been. Sri Lanka is one of the country where by vaccine they could have got herd immunity, and they could have been free. And these people are not thinking. The people at the top, unfortunately, is not thinking in this at all. Unfortunately.
No, so what is the vaccine situation, Ranjit? Are you getting vaccines?
They are getting vaccines from China and Russia.
Yeah, what is wrong with that? I mean, I know we don't like the politics, but what is wrong with the vaccine? I mean, they are vaccinating their people, right? The same thing, hopefully.
But the thing is, now these are being given to the provinces now, because they have given most of the Western province with AstraZeneca. So this Sinopharm and the Sputnik is being given to people in like the Kunnagala, Goa, Kandy, that areas. But now they say that with the Sinopharm, you don't get much immunity with the first dose. You need to get 2 doses to get good immunity.
Okay. No, but I think any vaccine is better than no vaccine. That's the point that I am making.
Absolutely. But it has to be organized, Karanian, unfortunately.
I mean, they must be. I mean, do we have a pretty good primary health system in Sri Lanka? So can you get the vaccine into 22 million people?
Yeah, what do you want?
Yeah, but there are a lot of people, politicians are like jumping the queue and trying to get the vaccination ahead of the high-risk groups.
In my apartment, so they're going to, can you get your man to go get
How about Canada? You got your vaccines there, Bonnie?
We are okay.
I took my first AstraZeneca in Saudi, and I took the second one day before on the 27th year.
We have taken our first, and we have the second one coming up today.
I finished with
the US has been wonderful, I mean, it's just
UK has done well.
US and UK also has done well, maybe.
Yes, UK has done well.
In the US,
one of the important thing there is other negative things that are going on, because people think vaccination is not necessary. The penny is good, and vaccination is not only for yourself; it's for the population as well. If you vaccinate yourself, you will be spreading the herd immunity, gradually bringing up the herd immunity. So people who refuse or are reluctant to go must be encouraged. I think there are a lot of negative vibes on vaccination that has come up with, even my youngest daughter, she doesn't like vaccination. She thinks there has been clots and there have been this, there have been that, all sorts of things.
AstraZeneca, yes, there have been some reports,
Yes,
few reports.
But very small number.
Have you heard of a report that was going round, or a message that was going round in WhatsApp about coming, apparently coming from a Nobel Prize winner? Anybody who had the vaccination will die within 2 years.
Yeah, I heard about it today from somebody.
Who is the Nobel Prize winner?
God knows, but that is
how the hell does he know? It has not been out for 2 years.
I don't know. No, but he's predicting. He's predicting that they are going to die within 2 years. So
it's a person who invented the AIDS virus.
I know. I mean, these kinds of malicious misinformation is rampant. I think is rampant, and it is part of the fear and unknown. And everyone is life is and community life is so disrupted, and yet you don't know what the hell it is. A virus, and you can't. It's a virus. You don't know. You can't see it. You can't fight it. Okay, and I know Sri Lanka is potentially in a dire strait. India was a mess.
Why is army controlling the whole the COVID system? Why can't
very strange, very strange.
But why can't the physicians be in the lead?
Yeah.
Because they have given him the lead because he was able to get rid of the LTT. He thought he will be able to get rid of virus.
Army will attack, shoot the virus down. This will help.
No, but the question is, one of the
advantages
of having a military is that I was in Jaffna when the COVID broke open, and within 6 hours the whole place was shut down. Of course, the northern east is so highly militarized; there are military all over the place. They are crawling all over the place. So but it shut it down, and in terms of virus spread, it caused a lot of human problems. But in terms of virus spread, the army was effective, and then they closed northern province off, so there was no influx of viruses coming in, and I think it helped to decrease the rate of infection because of authoritarianism and their methods which can make populations do things. No, I know that is a positive part. So there is something about militarized and compliant population that US doesn't have. In US, there are mad fellows even now saying, I don't want to wear a mask. I don't want to wear a mask and so on. So that is the positive side of it. The negative side is, they don't. I don't know whether they know the medical, epidemiological, and so on and so forth to be giving, and I don't know what their relationship to the doctors are. I don't know what the doctors' associations are doing, and whether and then you have this crazy.
Unfortunately, they have no authority. The health minister's husband is more influential than the doctors.
No, I know those are personal problems, but as a population basis, the fundamental thing is social distancing and isolation.
Yes.
And I think a militarized approach has helped that. I mean, it has helped in China. In Wuhan, for instance, the guys locked the place down for 4 weeks or 6 weeks or something like that, massive. You can't do that in the US. In the US, you are unable to get members of Congress to wear masks. So you have the other extreme of it.
SLMA and the colleges gave a recommendation that they should lock down for 10 to 14 days to prevent 2 cycles of the virus. But the thing is, politicians say the economy will be much affected by this. And
then they open up.
14 days. Initially, they wanted to have breaks every 5 days for people to go and buy their provisions. But ultimately, they have stopped that as well now.
It is also said that they have a policy of getting people who are positive for COVID and transporting them to a long area and putting them in a place of detention, essentially. So if someone is positive, they are transported to some long areas. I know in the north they have opened 1,000 in the Jaffna area, 1,000 beds of people who are being transported from the south with positive COVID in a bus and isolating them. Well, they are all over the country, I'm sure, but I know about Jaffna because I have contacts in Jaffna, and so they are doing that. That seems like an inane issue. I mean, it's a crazy issue, but I'm also told that the army gets money when you have more people isolated. So it's a money-making business too. So I don't know how much the decisions are made by economic factors and so on. But certainly when you have a centralized system like that, corruption is more likely to come in. And, so if you open up 1,000 bed, so I don't know all the ramifications of that, but
I think there's enough corruption.
So it is going to be a problem, but let's hope. The 2 weeks of now you are in lockdown, Ranjit, right? Ranjit?
I'm done.
You're locked down, right?
Are you in lockdown? Ranjit is on the phone. Sometimes it's.
Yeah. Okay. Narada, good morning.
Good morning. Yeah, sorry I was late.
Sorry, I have to apologize to Narada. I'm the one who gave the wrong information.
Okay, that's all right. Yeah. No, I had to go for a lunch and got a little bit late in coming.
So in England, you guys can go for lunch and socialize and all.
Yes, we are back. I mean, not back to normal, but we can. Yes, we can go to the restaurant. We can meet up. I think more than 6 people can meet even outside.
Hello, Narada.
Hi.
Narada, this is Bon Elena.
Yes, I can see that, Lena. Yeah.
Sujata.
Don says he's unable to join. That he will write down, and next time he comes, he will to tell us the other points.
So, gentlemen, let me just change the subject to something now. For the next week, is Koda still on the line?
Yes.
Yeah. Okay, I'll tell you. We will discuss 2 things. One is the next meeting will be on the 30th. I sent it to you. And it is on
Stanley's son is coming. Stanley's son is going to make Stanley Vijayasekara's son. He's a wonderful guy. Truly, he's an orthopedic surgeon at Yale University. So he's going to give us a talk. And
that's one. And the other thing we need to talk about now is: are you going to have a reunion in July 26th?
July 26th.
On the Zoom, but we need to contact personally people and work on this. Unless we start working now, we won't have that. So it is 1 year since we have started the Zoom meetings. I think at least have an annual reunion with more people coming in. Today, the maximum number, we had more than 20 people coming in, but we had at any one time, we had only 15 or 16 people. And
okay, Maruf, we'll lay out a plan and action items and ask people to do it. And we'll either do it next month, July or August.
No, we must start. Yeah, July or August, but that's fine.
But I think we need a little committee. I would suggest get Saro involved. And
Narada is involved already. Narada, I have him. Thank you very much, despite his lunch today. And you,
Benita, Narada, Sarojini, some creative folks have a little plan.
Enthusiastic guys, all right.
Yeah.
And anybody,
and then,
welcome. No,
Lawrence.
there's no limit. But anybody, I can be the central person. You can contact anytime, call me, or send me a text message. Come on Zoom. Every one of us begin to get Zoom oriented, and I will open my Zoom, and my number will be there. We can have a short meeting of a committee and discuss, and who we are contacted, who are the database. I will send it to you, and we start working on it.
Okay, we'll work on that and we'll get a little plan and circulate it among the small people.
Shanti is the other one. Then Shanti and Lal Jai Singh sent a beautiful song, and I told him this is nice to be sung at karaoke in our reunion.
So Banda has been. No, we need ideas for topics for discussion, and so next week is an activity. So one thing is, Banda was talking, Ranjit Banda, to me, and he wanted to know, maybe Lawrence is the person to answer this question. He wanted to know whether to have a discussion of life after death.
All right. We'll have to ask some people who passed on from our group.
It cannot be a double-blind study. It cannot be a double-blind study.
It is totally blind study.
People with experience.
Yeah. Yes. We have lots of members who have passed on. We can ask them to give us advice.
I know.
Ask them to join.
But the point is, he suggested that. I don't know whether just to have a philosophical discussion, instead of going into hard medicine like today, would it be helpful is the question. Anyone, any thoughts on that?
Yeah.
No thoughts. Okay, anyway, Banda was interested. Maybe we should ask Banda to talk about it.
I had a small quip, if you can spare me 1 minute, saying with the relationship of love and life. They said, you must love God because he created us. You must love life because God is the possessor and the controller of your life. But you are the carrier of your life. You carry your life yourself. So you have to love your life and yourself. So you look after your life. Then you have to look after your family, because family is the one you use your life with. You enjoy. And then you must also love your friends because they are the rest of the life. So the life is spread through God, starting from God, through you, to the family and to your friends.
We must add it on and say you must love your enemies too.
That's a good one.
Longer.
Oh, yeah.
So anyway, anyway, we need subjects. Anyone else?
I thought I was asked to do one on Narada's question of what's the point? What's the point of living this long life?
Correct. Yeah, we're going to do that too. I mean, so it is from that Banda also talked about. See, you cannot talk about the point of living unless you know about what happens after you die. So, but we will have, so maybe August we'll do that, Narada. You can wait till August. You stay with us till August before deciding it's not worth. For July, we'll do that in August, and then of course the reunion also we'll have to fit in somewhere.
I think I'm talking of July because we can work for it because 2 months.
But Maruf, unless we have very specific tasks for very specific people, it doesn't get done. And that's why I think we will have a little planning group and meeting, a small group meeting, and plan and then go forward.
That's why I've chosen Narada, yourself. I'm opening it.
Sarojini had good ideas.
Sarojini, fine. You mention, and all of us can have a Zoom meeting only.
Independently.
Our reunion.
Sure. We'll do a Zoom meeting next week.
All the people in this group can come in. No problem.
Happy birthday, Nova. Happy birthday. Talk to you later. I'm talking to all my friends all over the world.
Worldwide meeting.
Yep.
Okay, guys.
Anything else? We got a nice name for these meetings that we are having. It is called WW, and you put it upside down, MM, monthly meeting. Worldwide monthly meeting. But I think once a year we should have reunion. I think we are.
No, we will, Maru. We'll plan on it and get a small group to plan and do the work.
Why I said this is, next year, 12th meeting, which is 1 year complete, we have a reunion, and then we start again 1, 2, 3, 4 like that. and then it will be 11, 12 like that. And then when you reach 24, we have another reunion. So it will be nice. We have a system set in already.
Are you planning this for the next 20 years or what?
Maybe about 40 years.
That depends on Lawrence's talk. If Lawrence can persuade us to go on for 20 years, we'll do it.
I will give an anti-Lawrence lecture on that. How you can become younger by every year. You don't need to go to older. You say, a child 1 year, you ask, oh boy, how old are you? What? 1 year old? No. So how young are you? How many of us ask somebody's age as how young are you? Never. So we are conditioning ourselves to be old from beginning.
Good point, Maruf.
Good point, but what is wrong with being
Good
old?
point.
What is the value of being young?
What is the value of being young?
I prefer to be old than young. Narada doesn't even know whether that's necessary.
Old and wiser.
Yeah.
Young and active. That's what it is. I think we have an ability.
Kodi Kara, you are the wisest guy amongst us. Still, what do you think of all this chatter?
Scientifically, you have 22 telomeres. You have 50 trillion cells. Each of those cells multiply every 7 years. Okay, at the end of 7 years, the cell replaces itself and the old cell dies, and it loses 1 telomere.
How are you?
So all the 22 telomeres, once they are exhausted, you die. You have no choice. No cells left. So 22 times 7 is 154.
For the funeral.
That is your expected scientific ability to live.
It is where on the you send it on the but you send it on the WhatsApp.
And then if
on the WhatsApp.
There is historical.
Okay, you have my email. I'll call you back in a little while.
Now, if you notice,
I'll look at that
the
and see.
populations are going up to 90s.
Sure.
There's 90 groups, but they're not healthy. But recently they had a function in Australia where a 100-year-old lady was running, and they were doing races, and she got a prize.
Yeah, I saw that. I think there was a video about it.
I put it on the WhatsApp group.
Yes, you did, yeah.
So I think it's very interesting that we should have a positive attitude, positive health effect of negative ions.
Having
as many negative ions as possible. Next year, Lena, you will be 1 year younger than what you are today.
Okay.
We'll make you young.
Okay.
Okay, let's Lawrence tell the value of it, then I will tell you how to make you young. In 10 years, you'll be 10 years younger.
Maruf, you are a living proof of something that's working, so we'll find out.
Okay.
So Charles, Koda, what are your views on all this?
I don't know. I think Carlo must have been right in saying that after death, that's the end of it.
End of the story.
Carlo Fonseca said, once he dies, can give my dead body to the medical school, and that's the end of it.
No, that's the body.
Yeah.
That's the body.
You are the rationalist. Yeah,
let me ask you. You have 50 trillion cells. Where is your life? Where are you in that cells? In your heart cell, in your brain cell, in your nose cell, in your lip cell, in your skin cell? No.
Oh, no.
There is something inside you which is controlling this whole thing. That is called the soul. I don't know. I believe in that. Anyway, basically, I think this life is a thing that comes imagine all the cells. If you divide them into 23 and 23, they will die, excepting the germ cells. It is created for those germ cells to be half, and they live. And when you are born, you are a combination of 2 germ cells, which are 23 and 23. And after that, you start multiplying your stem cell continues to develop, and that the number goes to 600 million at 12 weeks of intrauterine pregnancy.
It is becoming too complicated for me. So can I be excused then?
Okay, I think I also have to chat. It's been a wonderful meeting. For the next meeting, we will hopefully get more people involved, and we'll have a little planning meeting for some people.
I think at some
But
time
thanks,
we have
folks.
to have a planning meeting.
Yeah.
Okay,
Thanks, folks.
bye.
And
Thank you very much for everyone.
Lena, wonderful joining. Lena,
Yes,
maybe
good
you
to
can
see Lena. Yeah.
enlighten us on some subject that you are very good at. You're a teacher also.
I think
And
he's in the
give us a
university.
subject. We like
University of
everyone to
Ottawa.
participate. Okay.
Okay.
Okay,
Bye.
Thank you, guys.
Okay.
Bye.
Thank you very much.
Thank you, thank you. Thank you, guys.
Thank you, Lawrence.
Bye.
Bye,
All the
Lena.
best.
Bye, Lawrence.
Bye, Lena. Good to
Bye,
see you.
Bye,
Bye,
Sai.
Bishop.
Hi, Kodikara.
Hi.
Bye, bye, Kodikara. We used to call him
Bye,
Cody.
Lena.
Hi.
Hi, Cody.
Hi. All right. Yeah,
I was in New Zealand looking for you, but couldn't find you.
but I'm in
Oh,
Scotland
he
now.
left. Only his children are there. One of his sons are there, and the other son is in Australia, right, Cody?
Oh, okay.
No. My sons are in, one son is in Australia, others are in Britain.
Britain now, okay. He has come back. No, the other son with you, and then another son, third one.
He's in Edinburgh.
Edinburgh. Oh, right. He's come to Edinburgh.
Thank you, Maruf.
All the best to you.
Great
Thanks
job.
for coming.
Okay.
And
Great
keep
job.
more people.
I was in terms of future subjects.
Yeah.
Would headache be a good one?
Very good one.
I'm asking that because my daughter is a neurologist in the University of Toronto.
Okay. Why don't
And
you ask her to give the talk?
her specialty is headaches.
Okay.
So that's something if you want.
Okay. Why don't you get in touch with her, and then you and I communicate with
Of
her
course.
on Zoom, and then we'll set it up. Yeah.
Sure. Excellent.
We can have it lined up. It's fantastic. We are
Indeed,
going to the next generation.
Okay. Excellent. Well done.
Lawrence, what is your topic now? I am still hazy about
Narada's question. What's the point of living into old age?
Yeah.
We can ask Narada to ask it again. So what's the point was his question? And it's called existential.
The value of living longer, right?
Yes.
I can give you an answer.
I
have an answer.
Yes.
Lawrence.
Yeah. Go ahead.
The value, the main value I have of enjoying my old age, God willing, is being with my grandsons.
Absolutely. So I'm going to look at the research. What does the research show on what are the reasons people find for living
you
longer?
love your family. You love your family.
That's
one meaningful.
That's one. But some people are happy.
You love your
themselves.
friends. Again, in this meeting has produced so much of energy for all of us.
Good.
Yes, meeting you all. Sometimes I worked 3-4 days or 5 days at a stretch, and night and day getting this gone. But then that's an excitement. Once I put it is a priority.
Right.
Bringing 100 people across, or of our own people to come together, it's a fantastic thing.
Yeah.
Indeed. Yep, I thoroughly enjoyed it. Thanks, Maruf.
Okay.
Nice seeing you, Lawrence.
Nice seeing you, Lena. All the best to you. Take
All the
care.
best. Bye.
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 How many of them did you talk to?
Nice meeting them, Lawrence.
Yeah.
I haven't seen him for a long time. We used to be good friends.
Lawrence? Yeah.
I know he came.
Thank you, Kota, for coming. And we'll see you at the next meeting.
Okay.
Okay.
All this to come and
all the best to you.
For my exam. I picked him up at Fulgate. You remember him? He came to you at Rustin House, I think, at the time.
Oh, probably, yeah.
So he came over here.
It looks good.
Thanks for downloading, Lena. You have been active getting into the Zoom, and now you are technology wise. I think the only thing that you lack now is there are 3 programs called WhatsApp, Signal, Telegram.
Okay.
All these 3 programs are very similar. You can download all 3 of them. The best of it is Signal. Okay.
Okay.
Telegram and any of these, you can talk on the phone for free anywhere with another person who has the same program.
Okay. So how do you get the Signal?
Signal is just put Signal. What phone do you have? Android phone?
Samsung.
Yes. You go to the Google Play and put Signal, Signal.
Okay. Okay.
You get it and download it, install it, and let me know. We can talk on Signal.
Excellent.
And then you have Signal, then WhatsApp and Telegram.
Okay.
Even WhatsApp, I can talk to you.
Okay, excellent.
One other thing, you have Facebook. Have you got Facebook?
No, no.
Okay. So at least you have these 3 things. There's one more thing called IMO, IMO.
Okay.
Quite a number of Sri Lankans use IMO. So
IMO.
download IMO as well.
Okay.
So IMO, Telegram, Signal, WhatsApp.
Excellent.
Okay.
But you're saying the first one was, what was the first thing you mentioned?
Signal. Did I say Signal, WhatsApp?
Oh, Signal, yes, Signal, yes.
Signal, WhatsApp.
Okay.
Telegram, IMO.
IMO, okay. Thanks, Maru.
And there is one more, last one more. If you're talking to Dubai or if you have friends in Dubai, Botim. B-O-T-I-M, Botim.
Oh, excellent.
Multiple people can speak on the Botim.
Okay, I can see
even
you
on, even on WhatsApp, many people can video conference call on WhatsApp.
I can see that you have mastered all these technologies. Good, good.
What we use.
Okay, we'll keep in touch.
Okay, we'll keep in touch, Lena.
Bye.
All the best to you.
All the best. Okay, dear, now we can exit.
Bye.
Now, you want me to send the flowers to?
You can end your picture like Lena.
Yep.
Click on your end button.
I'm sorry?
On the end button on the right side.
Yep.
It will tell you leave, so you can leave.
That one?
Yeah, end button, end. It's a red button.
Morning.
Right.
Can I switch this off? The phone is not going off. Switch it off. Turn it off. Yeah.
Did you find the end button?
No, it's coming Zoom, pro tip, update, login, sign up, search, Instagram.
There's a red button on the right corner, right bottom corner.
Yeah, right bottom corner. It says login. Right bottom, login, sign up.
Sign up and you must have done on Zoom already.
Yeah. So it will, I can just exit. That should be okay, right?
Exit. That's the one.
Okay.
Karunan is calling again. Okay. I can end it for you. No problem.
Okay.
Okay. Bye. You did it.